Why do some patients have weakness but the MRI is completely normal? Why does the numbness sometimes not mean nerve damage? And how can a simple test tell you exactly where the problem is, be it nerve, muscle, or even the spinal cord? In the next 10 minutes, I'll make EMG NCV so simple you will never forget it. Hi, I'm Kushi Thakkar, and in this series, we are breaking down EMG NCV into simple, clinically useful concepts. Before we jump into machines and waveforms, remember a good electrodiagnostic study is never done in isolation. It always starts with a proper neurological clinical examination because the real goal of EMG NCV is not just testing, it's localization. Is the problem in the nerve, the muscle, or higher up in the nervous system? In this video, we'll build up your foundation so you can actually understand what these tests are telling you and just not memorize them. Now we know this big hype about EMG NCV. It is so difficult, it is so important. Everyone keeps on saying that. So why do we actually do it? Let's discuss that. The main important aspect of doing it is an extension of clinical examination. So whatever you find out with your clinical understanding, clinical examination, you reach up to many differential diagnoses. Sometimes it is easy to get the differential diagnosis confirmatory, but many a times yet the clinical examination needs an entirely confirmatory test to understand the exact diagnosis. There comes our EMG NCV. It helps us understand the exact lesion location. It confirms the clinical diagnosis, whatever we have found out via our assessment. A confirmatory finding comes with EMG NCV. So it acts as an internal eye. Basically, it's a directed neurological examination essential before electrodiagnostic studies, emphasizing a lot that our assessment is most important in the reports of EMG NCV. Also, we see that in the end they have written kindly correlate clinically. So first is a clinical examination always, which has to be or may be followed by EMG NCV as per the requirements. It is essential to identify clinical abnormalities and establish a differential diagnosis. So tip is your hands examine the outside, that is you're examining the muscle outside, but or nerve, and the electrodiagnostics examines the inside. What is happening inside is what electrodiagnosis tells us. Let's understand body's wiring system. That is, how are the signals transmitted from the brain to the muscle. So the entire system goes on that the signals initiate or originate in the central nervous system, which then go, that is brain or spinal cord and many other areas. Then this goes to the anterior horn cell situated in the spinal cord. From there, the nerve comes out, that is the motor nerve. From there, it goes to the neuromuscular junction. Why not sensory nerve? Because sensory nerve goes in the opposite direction. Motor nerve goes from anterior horn cell to the muscle, and sensory receptors give away the information which is carried by the sensory nerve to the dorsal root ganglion. We shall discuss this later. So motor nerve, so it will go to the neuromuscular junction from where it will reach the muscle. So basically nerve is the internet cable and muscle is the computer. The CPU is the brain. Now we know that the whole aim of electrodiagnosis is localization. Localization where? So where is the lesion? It helps us understand there. The lesion can be in the CNS or it can be in the anterior horn cell, which is located in the spine, the anterior horn cell, the motor neuron, or now we will go sequence wise from the motor neuron or the sensory neuron, that is dorsal root ganglia. From these two comes our nerve roots. If the problem is in the nerve roots or which come together to form the plexus, so is the problem in the plexus, which then come out as the peripheral nerves. So we will be checking the limbs for that and the neuromuscular junction, and finally the on or end organ, that is your muscles. Now we know that localization is the aim of electrodiagnostic study. So it actually helps us providing diagnostic information when the disorder arises in CNS. For example, tremors as seen in Parkinson disease or cerebellar disorders or many other disorders, or there is upper motor neuron weakness or there is spasticity, everything can be understood. So this is just a visualization of what we discussed, the pathways. This is the sensory nerve root and the dorsal root ganglion. This is the motor nerve root and the motor root ganglion. I will be discussing why the motor nerve root is here and why the dorsal root ganglion is here and how it affects your interpretation in the upcoming videos. So these two combine and form the peripheral nerve. So we know the peripheral nerves are mixed. Now these two then go to the neuromuscular junction. The motor nerve will go to the neuromuscular junction and supply the muscle. The sensory nerve also goes to find and reach the sensory receptors which give away the information. The goals of electrodiagnostic studies. So first we divided into two goals. First is a localization, which we have discussed. Second is the severity. So localization, it helps us you understand three basic things. That is whether it is a muscle problem, it is a nerve problem, or it is a neuromuscular junction problem. Now we will discuss each in detail. For now, we will take in consideration the nerve. So now it will help us understand which fiber types are involved. That is, the pathology is neuropathic because we are discussing about nerve. So here, what types of fibers are involved, whether it is sensory, it is motor, it is mixed, or it is autonomic. Yes or no? You have to reply this to me in the comments. Next comes your pathology. Pathology. So whether it is an axonal, whether it is demyelinating, there is also one thing that is conduction block. So if there is any conduction block present, it also helps us understand demyelinating whether it is an acquired or inherited. Okay. Then next comes the temporal course. That is the nerve lesion. That is neuropathy. Is hyperacute, acute, chronic, subacute, or in what phase of the injury? And that helps us understand the prognosis, whether it is axonal or demyelinating. Axonal has poor prognosis when compared to demyelinating. It helps us understand what kind of prognosis and nerve fibers are involved. It also helps us understand what is going to be the prognosis, the rate of regeneration, and what regeneration has happened until now, understanding the temporal course. Now, localization, whether it is a problem in the nerve, that is neuropathy, neuropathology, or it is a muscle, that is myopathy, it is a pathology in the neuromuscular junction, or even the CNS. Now, moving on to neuropathy. So, if the neuropathy is involving the nerve cell body, that is neuronopathy, whether it is involving the roots, that is radiculopathy, or it is involving the whole plexus, that is the entire junction, or you see the accumulation of the nerves from the roots, that is forming a plexus, that is plexopathy. Or it is a mononeuropathy, means one single nerve has pathology. Multiple mononeuropathies means various nerves have multiple neuropathies, that is multiple nerves are involved but having an asymmetry and varying spatial and temporal features. Or it is a polyneuropathy, means all the nerves are affected. Next comes the myopathy. Myopathy, whether it is a proximal myopathy, for example, affecting the proximal shoulder and the pelvic girdle muscles, for example, in girdle muscular dystrophy. Or it is a distal myopathy, for example, Willander's myopathy. Or it is a generalized myopathy, for example, as occurs in myositis. Or even the craniobulbar, in which the craniobulbar muscles are more affected. Whether it is a neuromuscular junction problem, whether it is a presynaptic, that is before the synapse happens, junction comes up, or it is a postsynaptic. So postsynaptic, for example, myasthenia gravis, and presynaptic, for example, botulinum toxin or Lambert-Eaton syndrome. Or it is a pathology involving CNS. So we have to differentiate between the tremors and various other activities as seen on the graph. We'll be discussing that later. I hope the neuropathy part is clear. Now we will discuss about the myopathy. So it helps us understand the distribution of the myopathy, whether it is proximal affecting proximal girdle muscles, or it is distal affecting the distal muscles of the hand and the feet, or it is generalized, that is affecting all the muscles overall of the body symmetrically and equally. Whether it is bulbar, that is bulbar muscles are getting more affected, it is symmetric or asymmetric, and the severity of involvement. It also helps us understand the pathology, that is, it is bland or there is active denervation going on, or there are myotonic discharges as occurs in myotonic dystrophy. It helps us understand the temporal course, whether the problem, the pathology which has happened is acute, it is subacute, or it is in a chronic phase. All this is going to help you about definite your diagnosis, but also your management, because your management will vary according to the phase, and even your prognosis will vary according to the phase. Next comes your neuromuscular junction. That is, it helps us understand the distribution, whether it is a proximal, it is generalized, or is affecting more of the bulbar muscles. Whether the pathology is presynaptic or it is postsynaptic, and the etiology, whether it is an acquired or inherited neuromuscular junction disorder. EMG, EMG. What is this EMG? So it is basically testing the muscle. Okay, so EMG stands for electromyography. This is muscle recording. So basically it helps us assess the muscle health. It diagnoses motor neuron issues and it finds muscle level diseases. So basically there is a needle which is under all sterile precautions and various precautions indications is pricked into the muscle, and the electrical activity is noted at when the muscle is at rest, when the muscle is moving, contracting minimally, maximally, and the graph is recorded. That is electromyograph done via electromyography. It is basically listening to muscles electrical voice. It helps us understand what things are there into myopathic, which we have studied about the distribution, the pathology, and the temporal course. It helps us understand all of the three in detail and the diagnosis. Now NCV, so NCV basically is testing the wires. Wires is a nerve. So NCV is nerve conduction velocity, the speed with which the nerve is transmitting, that is conducting. The speed with which the nerve is conducting is nerve conduction velocity and is nerve conduction velocity studies. So it helps us understand the nerve health. If nerve is healthy, good health, quick action hoga, right? So if the nerve is healthy, the conduction velocity is going to be within normal limits. It measures the speed and strength of the nerve transmission, and it helps us understand the nerve block. It helps us again understand the neuropathic lesions of what kind of distribution is there, whether it is difference in the temporal courses, and also the pathology. So NCV is checking the speed of your internet cable, that is your nerves in the body. Now you know what is EMG and how it is tested. Now let's understand how is NCV, that is nerve conduction velocity, tested. So first we have to do is what? Stimulate the supplying nerve, that is it is stimulated by cathode. Why not anode? You have to answer in the comments, because this is already studied by you in your electrotherapy, Clayton, Low and Reed and Simplified. Next is recording happens at the muscle. Then you have to identify the distance which the nerve covered and the time it took to travel that distance. So if you stimulate here and you pick up here, this much was the distance of the transmission of the nerve. In how much time did it transmit that impulse? So it measures the latency, that is time delay between the stimulus you have given and the action potential which began in the nerve, and it measures the amplitude, that is response size. It is seen on the graph, the amplitude of the waveform. Okay, so the rule is black to black. Cathode faces active electrode. Cathode is always going to face the active electrode, and the ground electrode and reference electrode come later. The NCV which we discussed was how to test for a motor nerve. For a sensory nerve, we put ring electrodes at the distal fingers of the respective nerve autonomous supply, and we pick up the site and stimulate at the nerve particularly. We shall discuss about each EMG and NCV techniques later in the detail. So for now, let's remember this quick snapshot revision. That is, EMG tests the muscle. It is tested via needle. You put the needle into the muscle and test the activity, whereas NCV tests the nerves and it is tested via surface pads, as you see in the image. So EMG listens to your activity which comes out from the muscle, whereas NCV goes and stimulates and then find out what is the activity of the nerve. EMG helps us understand the myopathic lesions, that is disease of the muscles, and NCV helps us understand the neuropathic lesions, that is disease of the nerve. A basic flowchart of electrodiagnostic classification. So electrodiagnosis actually is divided into two components. They are done together always, mostly. So first is the nerve conduction studies and the other is EMG. The nerve conduction studies gives you detailed information about the nerve health, the sensory and the motor fibers of the nerve. So it helps us understand the motor fibers, compound motor action potential, which tests the motor fibers of the nerve. Next comes the sensory nerve action potential, which helps us understand the condition of the and any pathology involved in the sensory. After this is done, next what we see is the EMG. EMG, when you put the needle inside the muscle, there is immediate activity which we call as the electrical silence in the normal muscle. If there is any spontaneous activity present other than the electrical silence, means there is some pathology involving the muscle fibers. So we have to find that out, and then later we do a minimal contraction finding and then a maximum voluntary contraction finding. Seeing the graphs and the sounds which we hear, we can interpret the findings. Then you get the motor unit action potentials. We will be discussing what a motor unit is and how to diagnose that. Always remember the components of electrodiagnosis, NCS and EMG. NCS helps us understand nerve. Nerve में sensory and motor nerve fibers के बारे में it will help us understand. And EMG is basically your muscle, health of the muscle. In that we have spontaneous activities and motor unit action potentials characteristics. One quick revision, that is cardinal rules of EMG and NCV. So the nerve conduction studies and EMG are an extension of clinical examination. Your hands, your clinical examination is the most important. It will help you reach the diagnosis. If not, you will reach the differential diagnosis. And confirmation can be done using EMG NCV, which is very sensitive and reliable, and you have to correlate it with your clinical findings. Now, once your EMG and NCV is done, you can understand whether the findings on electrodiagnostic study are relevant to the clinical problem. When you are in doubt, think about the technical factors, artifacts which can happen with the muscle or with the machine. When you're in doubt, always re-examine the patient. Now combining all three, always think about clinical electrophysiological correlation. That is, kindly correlate your clinical findings with the electrodiagnostic findings. And when in doubt, do not overcall a diagnosis, please. Now, I wanted to put up a question for you. If a patient comes with numbness in the hands and fingers, but your entire electrodiagnostic study is normal, what could be the reason? Where the lesion will be in the nerve, but the nerve entire study is normal. So, is it possible that the lesion is above the dorsal root ganglion? Question 1. Second question, if a patient comes with wrist drop and complete radial finger drop, okay? Now, this patient says that this is happening right now since 2 3 days. That is, it is an acute condition. Now, in this acute condition, what is the reason? Is it a conduction block? Is it axonal injury or is it a demyelination? Now, in the acute case, you will not understand on clinical examination whether there is an axonal injury, whether there is demyelination, or whether there is only just a conduction block due to compression. All this will depend on the amount of and the duration of compression. But there is no objective measure to it until you do an EMG NCV, which will help us understand the entire exact pathology. Okay. So a quick revision, electrodiagnostic studies extend clinical examination, NCV tests the nerve speed, EMG tests the muscle activity, and the goal is always localize the exact lesion and the pathology. So if you understood this basic concept, you are already ahead of 80% students who just keep on mugging EMG and NCV for exams. So today you understood the most important foundation of EMG NCV. That is, it is not about machines, it is about clinical reasoning and mainly the localization. If you get this right, every advanced concepts become easier. In the next video, we'll go deeper into how exactly the nerve conduction studies work step by step. And if you are someone who wants to pass just beyond exams, that is, if you actually want to think like a clinician, not just memorize slides, I have created a mentorship program where I personally guide you through physiotherapy subjects from basic till your CET. It is not for everyone, but if you are serious about becoming a top performing physiotherapist, you can check the details in the description below. Thanks for watching this video. If you found this helpful, kindly like, share and subscribe to my channel and give me your comments. I would love to solve your doubts and have a discussion on the same topic.